Um, so a little bit about me. My name is Joe. Nice to meet everybody. I'm an inventor. I like reading a lot of research. I like going to medical conferences and learning. I found out that the carotid IMT, which is looking at the layers of the artery, is used in research. It's used in pharmaceutical research. It's all the statin drugs, depending on your emotional connection to them. They all had to prove uh, improvement. They all had to show improvement in the intramedullary lining to get these pharmaceuticals passed. So there's a huge body of research. Is the point that I was able to reference to give doctors, medical providers, and even patients kind of a reference as to where they are. So on the screen, you see an artery on the left to right. On the left, it's very healthy. That's probably what you'd see in a teenager. The next one, probably 20, 30-year-old, maybe 40-year-old. And then the rest is kind of how their body manages the disease. I'll go quick. I like this slide that talks about if a patient sees their arteries, if they understand their arteries, they themselves will reduce their risk of heart attack and stroke, cardiovascular disease by 50%. So just understanding it really changes behavior. What do we look at? We're looking at the carotid arteries on bilateral. Our anchor, or where we measure the same place every time, which is 1 centimeter proximal to the bifurcation. That's where we get our intima-media lining measurements. And you can see on this one that in the bifurcation, where the blood splits into two pathways, is the most common place for us to, not in every time, but looking in the bifurcation is the most common place for us to find plaque. Welcome, Dr. Zach. We're just talking about cardiovascular disease and setting the stage for how bad it gets. Patients who see and understand their cardiovascular disease will reduce their risk themselves by about 50%, just getting rid of sugar and things that they understand from the physician. We look on the carotid artery bilaterally. The intima should be thin and tight just about everywhere, but as we get older, you'll notice it getting thicker in the bifurcation. I suspect that's because of the shear forces of the spinning. Every time the blood splits into two pathways, there's going to be eddies in the stream. So if they do have dense molecules such as LDL, nicotine seems to be a bad one, seems to cause plaque to form in the bifurcation more than most. If you get systemic thickening, that's going to be metabolic issues. So let's look at it again. Carotid artery splits into two pathways. One feeds the brain, one feeds the face. And around the bifurcation is the most common place for me to find plaque. Plaque, we'll talk about it. You don't want it. You don't want any at all. But if you do have it, you want it to be calcified because that is the end of the disease process. So we're looking at two things, the inflammation of the walls and localized lesions of the plaque. I will point out the largest plaque to you and put it on the top right of the test. And the intima media, I'll give to you with a measurement. On this patient, it's 0.509. Zoom in. We'll review a test in a minute. Plaque forms in a few different ways. You get normal, consistent, on healthy people, it's thin and consistent everywhere. You may get a single lesion, which shows up on the walls. The lesion gets bigger, or you can have systemic thickening. Systemic thickening I see more common with metabolic issues. Too much sugar floating around, too much insulin floating around. And then when it gets really bad, that plaque will become protuberant. And if it's soft, it'll pop. If it's calcified, it'll be secure. It won't go anywhere. Secure plaque, there's a whole process to it. It takes years that I've seen to secure a plaque with calcium. And you need a dedicated patient to do it. So let's look at the first, the vascular age. This is just based off of the thickness of the walls, the intima and medial layers. Here in the green box, you see a reasonably healthy one. And again, on the left, you can see on the bulb how the wall starts getting a little bit thicker, a little bit chunkier. But for this vascular age, this person is about 0.5 millimeters, half a millimeter, pretty normal, giving them 74th percentile, which is getting up there. Actually, this patient is 0.728 millimeters, giving them a vascular age of 65, giving them a percentile of 74. All three of these are based off of the intima and media. We go down a little bit, we look at the layers. The intima and media appear to be together, but these are the layers where the plaque will form, and they do get thicker before you have an issue. Here's a healthy artery and a not healthy artery. I'm going to send everybody here this deck. You can see on the top one, the walls are thick and chunky monkey. Up top here, where the arrow is pointing, we usually put an arrow, well, we always put an arrow at the plaque or location of inflammation that we're looking at. And here you can see that it's dark, a lot like the blood. Dark in ultrasound density is brightness. So if it's dark like the blood, then it's liquid. The core of this plaque is liquid. It's held on by something of a cap, but not a very big cap. The science is whatever I find in the bifurcation is probably in the coronary tree as well. Here's some slides on how the damage accumulates. Foam cells, usually by plaque or some type of bacteria getting stuck in the mouth. Oral bacteria seems to be a huge issue. Lipid pools of liquidy, nasty stuff. The body will put in a fibrous cap. And over time, they'll put in little vessels called vasovasometrics, which will do the calcium exchange and try to calcify that plaque. Once it is calcified, it'll show up different on the ultrasound. It'll be bright. It'll be different density than the blood. Here's an example of a plaque that is soft and the technician is pointing it out. It's stuck along the wall. They're a little bit harder to see. Here's a transverse. Just so you guys know, you're going to get some patients that are more than 70% occluded. Your vascular surgeon does not appreciate getting patients 40, 50, 60% occluded. They can't do anything with it. But once it's over 70, you can send it over there and they'll put them on their list to get an ultrasound every year until they need a scan. This happened to my own father. Kind of mad at the system for this because there's no preventative anything. But yeah, I scanned my own dad and this kind of happened. Kind of a sad thing. The turbulence. A lot of docs will ask, well, why is the plaque forming in the bifurcation? And it's because there's turbulence. Red is flow going up to the brain. Blue are these little eddies in the stream coming back. So when your patient, when they do have dense LDL cholesterol or bad lipids, it's probably a dense molecule is getting pushed into the walls, that thin sensitive lining of the intimate media. Not a lot of research on it, but I've been looking into it. You can see exactly how it would form. It totally makes sense. So what can you do about it? I've been reading around, and the glycocalyx is becoming a real hot property. It's on top of the so on top of the layer that touches the blood, there's these little hairs, little cilia that blow in the wind. There's a negative charge on them to make sure blood doesn't stick. But it gets worn down, gets beat up. And there's some pretty good science saying that if you can put some type of astroturf in there, right now it's a seaweed that seems to seed it so it can grow better. That seems to be a pretty popular solution. So who are good patients for this? Your diabetics, blood pressure patients, your metabolics, family history, people who they're at the age where their father had a heart attack and they're concerned. And that's pretty much what the test is. Let me show you how you access it. We will give everyone, we'll set up a scan date a month or two in advance. And I think we can scan about every 15 minutes. You're going to log on to a portal very similar to this. And we'll look up my name just for this sales pitch. I scan myself pretty often because I'm tracking this disease. And this is what your patient will receive. Name, date of birth, all this information. Their intima-medial thickness layer, and then that transferred into a vascular age. So mine is about 0.5 millimeter. My lining is about 38 years old, which is pretty good, putting me in the 36th percentile for disease. Now, I also have a plaque in my artery, which I don't like, and it's mixed. It's heterogeneous. On the little things here, you can see how much blockage it's causing. So this is less than 20%. Let's look at some images. Here on the near wall, it's a little bit thicker. I'm being very picky because it's myself. I show the blood going through, and we show the anatomy. Let's take a look at the other side, see if this one's any better. You can see the walls starting to get a little bit chunky monkey, and I'm watching that. I'm eating better. I've lost some weight. So once the patient has seen the plaque, they can read about the intima, the membrane, damage to it gets worse. If they've been scanned serially, I scan myself weekly, so you don't get a nice over time. But yeah, I've been able to bring my intima down over time because I've gotten rid of a lot. Red is when events seem to start happening as far as inflammation. That's around 0.8 millimeters. Blue is average American male. Pink is average American female. Below that, we have descriptions of the plaque. You have a soft plaque, which are usually fresh and newer, hetero, which are mixed, and calcified, which are strictly calcified. They're stone. If you'd like, we give you the blood, the speed of the blood going through, and we give you a red, yellow, green on this. If it's above 150, that's when problems really start happening. And we also give you the size of each plaque. Usually they don't make the report till over a millimeter, but a plaque usually is 1.5 or more millimeters. We're just very picky, so we'll give you every little bump we see and give you the stenosis. So this is 6.1% blocked and 6.3% blocked. This report you can email to your patient. There's 2-factor login, so it's secure. And usually it's next business day after we scan. That's it. On our website, we have resources for your patients. At the end of this meeting, I'll send to everyone who attended a description of the test for a patient, some of the science behind it. But we charge $150 per report when we come to your office. If you have your own ultrasound machine, like this Butterfly, these machines are getting smaller and easier. A month or two ago, we had a breakthrough where we can receive a video from anyone. And as long as that idiot video shows a consistent sweep of the artery and some videos, actually, let me show you a couple pictures of it, just because I think this is fascinating. This is Butterfly. Everything that comes from that small probe uploads directly to the portal, and we can send it from there to our system. And when it comes over to our system, all we need is the video, and we snip out exactly the image we want. Let me pull up one of mine. We need a transverse sweep starting at the collarbone, and as we go up, the artery splits into two. This is the bifurcation. And the second video is showing us the intima and media. You'll see the lining right here in the artery. We'll snip out the pictures we need and measure those and get them to you to get this report. One of these on each side, and we can generate it. Our technician, when they do come, this is what we usually do is we'll set up a first scan date. We'll scan a few patients for you, and either at lunch or at the end of the day, or if there's a break, we work with you. You know, you scan a couple, scan yourself. If you got the hands, if you played a musical instrument, a lot of those docs pick it up pretty quick. But we'd love to. These probes are $3,000–$4,000, and patients are pretty happy to pay $150, $250, $300 for this test because they want to know. So if you guys do decide to get a digital probe, we can help generate and deliver this report to your office. All you need to do is go to DICOM management and send the report over to our system, and we'll get it.
I have a question.
Yes, please.
What's the difference in charges between if we had our own tech versus you sending one over?
About $75. $75 for the report and $75 for the tech to show up and do the scan. So $150 if we show up, and yeah.
Okay, and then you so if we had our own tech, it'd be $75.
Correct.
And then you just mentioned a range on price. You said like $150, $300, $400. Are there different tiers and added information for the higher end, or what's the range for?
Where you live. Some offices charge $300–$500. Some charge $149. $150, like pass it along. We recommend $199, $249. It's reasonable. And when insurance totally pays for it, patients just don't give it the attention it needs. My opinion.
Mm-hmm.
So how is this different than like a regular ultrasound of the carotid arteries that we would send someone to
Like-
our local hospital?
Yeah, they will also tell you degree of stenosis, but they won't tell you intima media usually. They won't give you a vascular age. They won't put it in a format. And it's usually strictly pre-prep for surgery, or are they bad enough for surgery? So it's more, although we get largely the same measurements. I mean, we get a few more, but ours is geared for heart attack and stroke prevention. But yeah, same technology, same everything else.
Well, and Dr. Pegg seemed to indicate what you were providing with the intimal thickness. That was the part that she was saying you can't get from other ultrasound sites. Is that true?
Yeah, nobody takes the time to measure the intima medial lining. It's done in research. We do it in research for others, but it's just a special, it just happens to be a specialty in this industry. Radiologists don't, vascular surgeons don't seem to acquire it routinely. And I rarely see it unless there's like a dedicated preventative program.
Interesting.
Yeah. All right. I'm going to assume Sale and
So
ask you
Joe,
a few
I've got
questions.
just two questions here real
Yes,
quick.
please.
As far as data for research, do you provide that so that we can pass that along to patients so that they can understand the differences as far as what you do and the benefits? Okay.
Yes. We got some prepackaged emails I'll send at the end of this.
That's great. And then the second thing is we wanted to get our own ultrasound because I've been looking at this for about 2 years now. We've done some research on it. Is there parameters that you recommend from a standpoint of carotid and what?
No, they're getting pretty good, all of them. I mean, I've played with 3 or 4 different ones in the last year. I got a Sonon here. I just gave back an Eagle View. They're all pretty good. I'm liking the Butterfly right now though, because it's got a digital head.
Mhm.
These analog ones are great, and you get one line of data, but this allows me to get 2 views at once. So I can see the transverse looking down the tube, and I can see the intima on the, like this is a huge breakthrough, and it's just the first version of it. It's about $3,000, 2,500. And yeah, I can teach you in a few hours to get my test.
Okay.
My next one I want to do is like fatty liver. I think there's a huge need for that. But I think it's probably going to be in your future. They'll be on your cell phone in about 10 years. But for right now, yeah, digital probes are where it's at.
I have a question on the training piece. So if we want to train one of our employees how to use it, do you have any recommended trainings to do that?
No, you can send them to a 3-day course somewhere in the country, but really it's time scanning. Somebody who's probably pretty good with their hands and doesn't mind playing, but they're so cheap now. Yeah, it used to be a $40,000 investment, and now it's 3, which is way more accessible. So yeah, if there's someone on your team, what I recommend is we set up the date where my people come. We do it, we get you used to it, we go through a few, and then your person, we'll train them. And then every month that we come back, or quarter, whenever we come back, we spend some time. It's not very expensive for us to train. So as long as they're willing to upload a few studies a week, we'll process it and then give feedback. And usually within a few weeks of that, we can get them up and going. But the ability to look at pregnancy, the ability to look at fatty liver, the ability to look at the heart, the thyroid, these are powerful tools.
I've been wanting to get a Butterfly just for the pregnancy piece of confirming the vertex position and not having to send people to the hospital for that. And, I feel like I'm getting more and more cardiovascular patients and with an aging population. And it seems so critical to then be able to know where you're at.
Yeah.
And Sarah, for what it's worth, I've done this now in my my clinic, and I did it with a doctor who's done a lot of history on this as far as ultrasound, and he offered a clinic. It was the single most powerful tool that I've used so far to encourage change in my patients from a cardiovascular standpoint. When they see the plaque, that for some reason hit them harder than anything else I've done discussion-wise. Maybe that's my bad encouragement, but I think it's really the power of being able to see it on the video and say, that's my body, and there's a plaque there, and I need to do something about it.
Absolutely. When they
That's
see it,
really
it
cool.
all resistance washes away. Stop the recording.